Hello everybody, my name is Stefan Orszulik and I have a background in process improvement and quality, and I'll be talking about the quality of antimicrobial discs. Now, as you know, these discs are a very cost-effective way of checking for which antibiotic is best to use in a clinical setting, and manufacturers test these discs according to a particular procedure, which is a quantitative method. End users use quality zone sizes, and so these are two very different methods for testing their quality. Both these methods have certain issues, and I'll be talking about these issues and also providing some possible solutions. Of course, what is important is the outcomes, and when these tests are carried out, the outcomes depend on two main factors. One, the main factor is the quality of the discs themselves, and once the plate has been read, it then depends very much on the accuracy of the breakpoints. And I'll be looking at each of these separately. So on quality of the discs, there are quantitative measures which are used by manufacturers. And there are also quality zone ranges which are published by bodies such as UCAST and CLSI. And so I'll talk separately about each of these when looking at the quality of the discs. And I'll also have a look at the accuracy of the breakpoints, seeing how they are estimated and how good are they at predicting clinical outcomes. I'll just talk briefly about the theory of disc diffusion, and this is described by this equation here. It is based on Fick's law, which quite reasonably states that the rate of diffusion is dependent on the concentration gradient. This equation is published in 1999, so the reference is here. We have the concentration of the antibiotic at a particular point R, which is the distance from the center after time t. A is the amount of antibiotic on the disc, D is the diffusion coefficient, and small d is the depth of the agar. And we have, if you look at this equation, you will note that there is a theoretical relationship, a linear relationship, between log of the amount on the disc and r squared. And this becomes important as will be described in the following slide. Manufacturers make discs according to a specification, and there are three main specifications. It's the WHO, the FDA, and DIN, and these percentages are the amount that is on the disc, and it's the average amount on the batch, and clearly there's a range that is allowed. The widest one is for FDA, which is 67 to 150% of the amount that's stated on the label. And not only do they give this specification, but they also give a method for testing the discs. And this is an assay, so it's a quantitative assay. And it is a linear method. And an example of that is given here. So you take 50%, 100%, and 200% of the amount on the disc, and you measure the zone size and you draw up a calibration line. And the calibration line is drawn up using log of the amount on the disc against zone size. Now, as we saw on the previous slide, theoretically, the linear relationship is between log C and the square of the zone size. So already we have here a problem in that this does not match theory. Theoretically, this shouldn't be a straight line, and in practice it often isn't. So if we look at this particular example, and it's an example taken from the WHO manual, and here the manual describes how to carry out the assay. And if you look at this example, you will see that there is already a certain amount of curvature. These don't line up as a straight line, and there is no requirement from any of the three standards to ensure that it is a straight line. They simply state you produce a straight line, and that is your calibration line. And taken from this example, there is already a 13% error due to curvature. So if you take a measure across and you then read off what the concentration is, the concentration here is on a log scale. So when you anti-log it, you get a bigger error than you might think just by looking at this graph. Now, it is possible to have a three-point assay, and it involves a transformation, and the references are given here. But if it is not a straight line, then such assays are invalid, and they are theoretically invalid, and in practice they are very often invalid. End users don't use an assay to test the quality of the discs. They use quality zone ranges that are published by various bodies, including UCAST. So it'd be useful to know where these quality zone ranges come from. Now, what they do is they take discs from a number of manufacturers, and they carry out the tests using different media, people and places, different laboratories, and they capture all of that data set, and they apply a 2 sigma variation to that data. So they capture 95% of the variation to set the quality zone ranges. Now, there is no justification given for a 2 sigma being used. It's perhaps not unreasonable, but it's not known where that comes from. So what happens is that a batch of discs, which may have typically a range of 1 or 2 millimeters, ends up being a quality zone range of 8 to 10 millimeters. So that means that it is quite possible for poor quality discs to pass the test. What you're in effect doing is you're using manufactured discs to check manufactured discs, and that is not valid. It is, if anything, it's an example of bad science. It is not a quantitative method, and it is fundamentally unsound. This is a table published by UCAST, and it compares different manufacturers and various discs from 2014 and 2017. Now, it's a very busy slide, and I'm sorry for that, but you don't need to look at this in detail. What you can see is that there are a number of batches, discs, that are out of spec. These are the ones that are in red, and the ones that are in green are in spec, and the other colors are ones that are close to being out of spec. And what you can see is that there is a general improvement between 2014 and 2017. What you don't know is how many are in spec or out of spec quantitatively. What you can see is that in 2017 here you get roughly the number out of spec that you would expect, on the basis that these are done by quality zone sizes, and you'd think that roughly 5% would be out of spec. It's not a proper measure, as explained earlier, so there isn't a great deal of new information here. There's not much to be gained from this sort of study, apart from perhaps that there has been a slight improvement. So the important question here is, what is the true quality of discs? And by true quality I mean quantitatively, how much is actually on the discs. And if you look in the literature for quality of AST discs, you will find that there are very many studies looking into this, and they virtually all use quality zone ranges, which, as we've said, is not a proper measure. If you're looking for quantitative studies, there are very few. But there are a couple more recent studies, and here is one which looked at amoxicillin clavulanic acid. And they found that only 22% of amoxicillin discs were within spec. There was 46% were within spec on amoxicillin on this combination disc, and there were none that were in spec on clavulanic acid. Now, this study included a number of different manufacturers, including all the main manufacturers that you will be familiar with. So this is possibly quite a representative sample of the sort of quality you might expect. There was another study carried out. Again, this one looked at amoxicillin clavulanic acid discs, and they found that none of these discs were in spec on amoxicillin. Of the ampicillin discs, 67% were within the specified limits, and only 33% on ciprofloxacin were within spec. Now, if this is representative of discs in general, you would come to the conclusion that many, or even a majority of discs, are out of spec. And this is not what you would expect when you're looking at the quality zone sizes as shown on the previous slide. But as said, the quality zone ranges is not a proper measure. Quantitative analysis is a proper measure, and that gives you a very different picture to the true quality of discs. So, what are the implications for clinical outcomes? We've looked at the quality of discs using the assay and using quality zone ranges, and there are certain concerns about these issues. But if the clinical outcomes were fine, if discs were good predictors of clinical outcomes, then there shouldn't be that much of a problem. So if you have a look in the literature and you look for AST discs and clinical outcomes and PICO and other relevant terms, you will find that there is no overall study at how good discs are at predicting clinical outcomes. There are a couple of individual studies in particular circumstances, which we'll have a brief look at here. But surprisingly, despite over 70 years of use, there is no study that tells you the overall effectiveness of AST discs. So one study showed that there's about a 3% error using discs and using the UCAST breakpoints. And of these, 1.3% were very major errors. Now, it's not known if this is acceptable or not, since the criteria haven't been set, but this is probably more than most would expect. There was another study carried out which found that major errors are common, and there was a comparative study done using different AST methods, and it found that disc diffusion had the lowest acceptable results at just over 81% amongst 11 laboratories. So there are suggestions here that discs are not a particularly good way of predicting clinical outcomes, and so there are some concerns around this. So to summarize, the assay that is recommended by DIN, WHO and FDA is not valid. So this is the assay that is carried out by manufacturers. The quality zone ranges that is published by a number of bodies is not quantitative and is not a valid way of checking the discs. So if you look in the literature, there is very little that tells you what the true quality of the discs are, and the information that is there would suggest that many or most are out of spec. If you're looking at clinical outcomes, again, there is not much data, but it suggests that discs are not a good predictor of clinical outcomes. There's another point here that you may wish to consider, and that's to do with harmonization of breakpoints between these different bodies, UCAST, FDA and CLSI. They all have a similar way of working out their breakpoints, not the same, but they are similar, and you would expect them to be reasonably well harmonized. Now, there are many instances where they are not harmonized, and that leads to the question of why do they not appear to line up, and is it due to the quality of the discs or the quality of the systems themselves? The information that I'm presenting here has been shared with UCAST, and they have not disputed any of these findings. I'm not sure they like them, but they haven't disputed them with any information or data. But they have said that they themselves do not hold any quantitative data on discs. And that would then undermine any of the information that comes from UCAST if they do not know the true quality of the discs. So that would include the quality zone ranges and the breakpoints. But it's difficult to know how good or bad the system is, because there is a lack of proper data and lack of a proper scientific investigation into this area. So just to finish on a slightly more positive note, there are solutions to these issues. They may not be easy to implement, but they are reasonably straightforward. One is that manufacturers should use a validated quantitative method to check the quality of the discs and should be audited against those methods. There is a 3-point assay method available that is valid. Manufacturers may choose to use a 5-point assay or other methods, chemical methods, HPLC for instance. The quality zone ranges and breakpoints should be set using only quality discs. That means discs that are known to be in spec, and then the effect on clinical outcomes and antimicrobial resistance should be looked into using only proper high quality discs. So all the data given in this presentation is based on published data, peer-reviewed data. So the first two references, 1 and 2, are concerned with the manufacturer's method of assaying it, and reference 2 shows a way of carrying out that assay fairly simply but in a valid manner. 3 and 4 are publications from UCAST, one giving how the breakpoints and the quality zone sizes are determined, and the other one on the quality of discs using that method from 9 different manufacturers, and that shows a significant number of discs are out of spec even by that method. Reference 5 backs that up. It suggests that around 10% of discs are out of spec. Now that is a limited study, but it backs up the study given by UCAST. Reference number 6 is a look at the performance and the quantity of antimoxicillin and clavulanic acid discs, and that shows that less than half the discs are within spec, even using quite a wide spec in that particular case. And the last reference gives some information to do with disc quality and clinical outcomes. The information is very limited, but this gives some indication of the sort of errors and major errors that might be present on using antimicrobial discs. Thank you for listening.